Oh, hello there. Welcome back to the workstation. Today, I have a very curious case of a CT scan of the brain of an elderly patient that complains for the last few months of a progressive headache that just won't go away. So the family got really worried and took him to the ER to see if they could find any cause to such a headache. He had already suffered from a few past ischemic strokes, so the family is always worried if that headache isn't related to a new ischemic event. So let's see the images right now. So this is a CT scan, a computed tomography of the head. So these are sectional, cross-sectional, transverse images of the head of the patient. And if it's your first time here, let's just do a quick recap. So the patient is lying down on the exam table, on the scanner table. His nose is facing up. His nose is facing up. This is anterior, this is posterior, this is left, and this is right. These are the eyes. These are the ears. We are looking at the base of the skull, and this is the back of the head, the occipital region. So you have to picture yourself as if you were by the sole of his feet, looking forward, and the scanner is making the cross-section images and showing to you, so you have to orient yourself accordingly. So we are looking for a cause of chronic severe headaches on an elderly patient that has already suffered ischemic strokes. You can see right here on the basal ganglia and the thalamus a few ischemic lesions, some lacunar stroke lesions. Let's see if we can see anything else on the parenchyma. It seems the parenchyma is alright, just old lesions, no signs of blood, no signs of masses, except for this odd looking sphenoid sinus and cellar region. Right here we can see, we just window it a bit, we can see these are vascular calcifications. These are vascular calcifications related to the carotid arteries, the internal carotid arteries. So these are the carotid arteries. Between the carotid arteries, we have the cellar region where the pituitary gland is, also called the Turkish cella. So it is a bone cavity that holds inside the hypophysis gland. So this is usually a very distinct bone structure. It's clear to me that the contours, the walls of the cella are eroded, and there is something that extends to or from the sphenoid sinus cavity to the left. So there is a soft tissue mass that much resembles the density of the brain itself. It's occupying the left sphenous sinus, and it's eroding the floor of the cella and taking the approximate site of the hypophysis gland. This is more than enough to justify the symptoms the patient is complaining about. So let's hit the MPR button and let's see this lesion from the sagittal view, which is the most useful view to look for a cellar lesion. So this is very, very clear right here. Just get it bigger. So we are here at the cellar region, as you can see here, and as a reference right here. So as we can see, we have here is the hypophysis cavity, the cella, and here is the sphenoid body with the sphenoid cavity, the sinus itself. So there is a soft tissue mass, a very aggressive soft tissue mass that partially occupies the left sphenoid sinus and extends through an erosion of the cellar floor into the cavity itself, and it takes over the entire parenchyma of the pituitary gland. The pituitary gland is gone. All that we can see here is a soft tissue tumor. So in cases like this, we have three differential diagnoses to make to justify such presentation. Since we have no prior history, you have no biopsy, we have absolutely no history of any kind of prior disease. The patient didn't know he had a tumor on the base of the skull until now, so we have to at least explore our possibilities. So we can have both a lesion that originates from the sella and goes down into the sphenoid sinus, or we may have a chronic lesion of the sinus, of the sphenoid paranasal sinus, and that erodes the floor of the cella and goes upwards into the brain cavity, taking over the hypophysis gland. In the first case, the most common tumor that behaves like this is an aggressive hypophysis adenoma. And on the other hand, the two most common presentations of chronic lesions of the paranasal sinus that go into the brain cavity and erode bone are mucormycosis of the sinus, which is a fungal infection, chronic infection of the paranasal sinus, and the most common cancer of the paranasal sinus, which is the squamous cell carcinoma. So this could be a squamous cell carcinoma going towards the hypophysis gland, or it could be a chronic aggressive fungal infection of the sinus going and taking over the hypophysis gland. And also it could be a primary neoplasm of the hypophysis going downwards into the sphenoid sinus, eroding the floor of the cell. So if you enjoyed this video, I'm pretty sure you're gonna enjoy this here also. So just click here and keep watching. Thank you so much for watching. Like, share and subscribe, and I'll see you in the next video. Take care.